Hi, my name is Dr. Harini, and today I'm going to be explaining about Tetralogy of Fallot, which is a very commonly asked 10 marker or a 5 marker in the final exam of MBBS, and it's a pediatric congenital heart disorder. We're going to be discussing this under a few subheadings. Firstly, we're going to see the components of Tetralogy of Fallot. We're going to see the mechanism of how the disease occurs. That's basically the pathology or the physiology of the disease, pathophysiology. And we're going to discuss about the murmurs or sounds that can be heard in this condition, clinical features, investigations that can be done to diagnose, treatment modalities that are available, and complications. So, as the name suggests, the disease contains 4 components, tetra meaning 4, and these 4 are basically number 1 being a pulmonary stenosis, a ventricular septal defect, a right ventricular hypertrophy, and an overriding aorta. So I'm going to draw a simple box diagram of the heart here for better understanding to see what these defects basically are. So this is the superior vena cava, inferior vena cava, pulmonary artery, aorta, pulmonary vein. So the first component is a pulmonary stenosis, which is basically that congenitally the baby is formed with a defect in the muscular layers of the pulmonary artery such that there is a stenosis. So this is some sort of kinking due to which the pulmonary artery is stenosed. The second is a ventricular septal defect, meaning the ventricular septum, which divides the right and left ventricle, has a perforation or a septum, and this is usually a high ventricular septal defect. This is present at the upper region of the ventricular septum. And the third being a right ventricular hypertrophy. So here there's outflow obstruction to the right ventricle. The blood is unable to flow from the right ventricle through the pulmonary artery and to the lungs. There's obstruction to the outflow, due to which there's accumulation of blood in the right ventricle, and there is increased pressure in the right ventricle, leading to hypertrophy or increase in the right ventricular size. And the fourth component is an overriding aorta. We know that the aorta ideally leaves from the left ventricle and ensures systemic blood supply. So here what happens in this disorder is that aorta emerges from the right ventricle instead of the left ventricle, and it overrides the septal defect, as in it's present above the septal defect and somewhat like this to represent it pictorially. So it overrides the septal defect and emerges somewhat from the right ventricle. So these are the 4 components of tetralogy of Fallot, and it is a cyanotic congenital heart disease, and by that we mean that there's mixing of deoxygenated blood with the oxygenated blood. We know that the left ventricle contains oxygenated blood and the right ventricle contains deoxygenated blood. And here what happens is, in normal setup, the right ventricular pressure is lesser than the left ventricular pressure. So invariably blood will flow from the region of high pressure to low pressure. But what happening in this congenital disorder is that because of the pulmonary outflow obstruction, this stenosis, and there is outflow obstruction to the right ventricle, so there's accumulation of blood here, leading to increased pressure in the right ventricle compared to that of the left ventricle. And so the shunt is a right to left shunt. Through this pulmonary defect, to the septal defect, the blood moves from the right ventricle to left ventricle. So oxygenated blood here is getting mixed with deoxygenated blood, and that is leaving through the aorta into systemic circulation. That's why the disease is cyanotic. So if you can understand that, then the mechanism becomes simple. So first part of the mechanism is that there is a right ventricular outflow obstruction, and this is, like we said, because of the pulmonary stenosis, and this leads to right ventricular enlargement and hypertrophy. And this increased right ventricular pressure invariably leads to a right to left shunt through the septal defect, and this causes cyanosis, which is central in nature because this is happening at the heart centrally, which is leading to supply of deoxygenated blood to the rest of the body. So we're done with the components mechanism. If you can put it in a flowchart manner, it's easier for you to, get marks. And the third part is what are the murmurs or sounds that can be heard. So on auscultation, there are four main things you should remember under this. The first thing is that there's a normal S1, there's a single loud S2, and the third part is that there's an ejection systolic murmur and an aortic click. Sometimes it's very occasional. You can choose to not mention this also. First one is it's a normal S1. So we know that the S1 component of the heart sound is due to closing of the tricuspid and the mitral valves. So that S1 component is absolutely normal because there is no valvular defect. So we know that the S1 is normal. And the second is S2. Know that the S2 is physiologically comprised of two components, that is closing of the pulmonary valves as well as the valves of the aorta. And here what happens is that there is a single loud S2, and instead of having two components, that is both P2 and A2, P2 is heard. This P2 is almost inaudible. This is because obviously the pulmonary valve, the valves of the pulmonary vessel is T-nosed, so this P2 is almost inaudible and we can hear only A2. So the single loud S2 is only because of A2, that is closing of the valves of the systemic aorta, and so we hear only a single loud S2. The valves of the pulmonary artery is T-nosed, so it doesn't make noise when it closes. So it's single loud S2. And when we hear also something called an ejection systolic murmur, which is very important, it's heard between S1 and S2. And we know that S1 is due to closure of the mitral and tricuspid valve, and S2 because of closure of P2 and A2. What happens is as the blood flows from the atria to the ventricle, there's no murmur because this area is fine. From the ventricle, when the blood leaves the heart through the pulmonary vessel, it passes through an area of narrowing. So normal vessel is like this. Here the vessel is T-nosed, and so obviously there is turbulence to the blood flow, and this creates a murmur or noise which can be heard on auscultation. And this is occurring due to the ejection cycle of the heart, that is the ventricles are contracting. That is when this murmur is being heard, and it's heard during the systole. It's heard before S2 and before S2 and after S1, and thus it's an ejection systolic murmur, and it is represented like this diagrammatically. It's a diamond shaped murmur as it passes through the stenosed pulmonary artery. So its ejection systolic murmur can be heard, a single loud S2 that is only an A2 component, which is with an almost inaudible or a silent P2, and an aortic click can be heard sometimes, which is very occasional. This is because of high amount of outflow that's occurring through the aorta. Ideally, the aorta is supposed to take out blood from the left ventricle to the rest of the body, so it is draining only one ventricle. But in this congenital disorder, because it's coming out of the right ventricle and because of the septal defect, the aorta is draining blood from both the right and left ventricle. So it's draining out more than the usual volume that it drains out. So as soon as the blood gushes out in high pressure out of the aorta, the aortic valves close with a click, and that is known as an aortic click. So these are the four main sounds that can be heard. You need to mention an ejection systolic murmur, the normal S1, a single loud S2 because of only A2, and an occasionally heard ejection click. So going to clinical features of the disease. Firstly, the patient or baby will present with cyanosis, evidently because there is central cyanosis occurring. There can be clubbing. The patient will have dyspnea, and dyspnea on exertion can be seen, and this level of dyspnea is directly proportional to the shunt. So as the baby starts walking and running, it will start presenting with dyspnea. They might have growth retardation, and they can present with something which is very classical of tetralogy Fallot, which is known as tet spells, also known as cyanotic spells, or um, tet spells or cyanotic spells. And this is a very classical tetralogy of Fallot clinical feature. This by itself can be asked as a 5 marker or a 3 marker. So what basically happens is, this baby, the patient will come to you with a complaint of that my child is always squatting, or it's always like when the baby's on the mother's lap, it's with a knee to chest position. And this is because this is the body's mechanism of reversing the shunt that is already there. So when the baby goes into a squatting position, that is the knee is to the chest, what happens is there is increase in peripheral resistance. So the systemic vascular resistance is increased, right? And because of this, the blood that is reaching the heart, so this is the so the output of the left ventricle is the aorta, right? So what's happening is there's increased systemic vascular resistance. So the force against which the aorta is pumping out blood is increased, due to which the output is decreased. So this output of the aorta is decreased because this force, systemic vascular resistance, is high. And so what happens is the stroke volume, that's amount of blood coming out of the left ventricle, is decreased. This leads to increased pressure of the left ventricle, and this causes reversing of the shunting. So, in this disease, we saw shunting between the right ventricle to left ventricle. Now, because of this increased systemic vascular resistance, the whole thing is reversed. So, this leads to, it doesn't reverse the shunt completely, but it at least reduces the amount of blood flow from the right to left. Because of the increased pressure in the left ventricle. So, now it prevents the right to left shunting, and it thereby decreases the dyspnea. So this child feels better when he's squatting or when he's in a knee to chest position, because this increases the SVR and it decreases the stroke volume, increases the left ventricular pressures, and prevents the RV to LV shunt and decreases the dyspnea. So this provides some sort of comfort, and this is known as a TET spell or cyanotic spell, which is very commonly seen in tetralogy of Fallot. And going on to investigations that can be done, ECG obviously can be done, and this will show that because of right ventricular hypertrophy, it will show a right bundle branch block. But pediatric age group, not very easy to perform an ECG as well as interpret it. So most important investigation is an ultrasound, and when you do an ultrasound, what you see is known as a boot shaped heart, and this is come in most MCQs. So because of the kinking of the pulmonary artery because of the stenosis and that right ventricular hypertrophy that we discussed, the heart takes somewhat the shape of a boot, also known as a boot shaped heart. And in chest x-rays, you'll see that there is decreased lung vasculature. This is because because of the pulmonary stenosis, less amount of blood is reaching the pulmonary vessels, so lung shows less pulmonary vasculature. And this is pretty much it. You can choose to do an MRI, obviously it will show the default much clearly. So what are the treatment modalities available? There are two modes, that's medical and the other is surgical. So medically, you can advise that in case of spells, these these situations when the patient goes into dyspnea, has a cyanotic episode and loses consciousness, this knee heel position can be explained to the parents, and that this will at least restore the blood flow till they reach an institution. So the knee heel position can be explained, and that they can use it when the baby is going into cyanosis and is losing consciousness. And obviously oxygen, because the baby is having decreased blood oxygenated blood supply, so oxygen. Morphine to reduce the pain, also depresses the respiratory center. So when the baby is cyanotic and it's in dyspnea, it tends to have tachypnea. So that is one of the clinical features that you need to mention. The baby has tachypnea. They try to they have dyspnea and tachypnea. They tend to breathe faster because they do not have enough oxygenation. So in order to avoid this tachypnea, morphine suppresses the respiratory center, and then propranolol can also be given, and then obviously vasoconstrictors by themselves can be given. And you can, so if the baby is having prolonged cyanosis, it will go into respiratory acidosis because of the tachypnea. So you have to treat the acidosis with bicarb, and you can maintain a patent ductus arteriosus by giving prostaglandins. So you know that a patent ductus arteriosus is again a congenital heart disease where there's communication between the pulmonary artery and the systemic aorta. So what happens here is, if you maintain this patency, then the amount of blood flowing out to the systemic aorta can be shifted out between both. So the outflow through the systemic aorta can be divided between the both. It will reduce the pressure and give us some time to, work on the condition. So by maintaining a patent ductus arteriosus, it usually disappears after birth. So you can maintain it by giving prostaglandins till surgical repair can be done for the baby. And otherwise, if the baby is going to sepsis or any sort of infection, you can supplement with antibiotics. And surgical modality of treatment is, what happens is you can correct the ventricular septal defect. That's one option. The other is you can correct the stenosis, and you can put a stent to make sure that the pulmonary artery remains patent. And complications, it's very understandable. The baby can go into syncope, and loss of consciousness and death can occur because of the respiratory acidosis. And there can be infective endocarditis because there's stasis of blood in the heart. There's slowing down of blood in the heart. There can be pulmonary emboli formation, and there can be infective endocarditis. Bacterial infection can occur, sepsis can occur, and this sepsis can cross the blood-brain barrier and can also lead to brain abscesses, etc. So this is basically tetralogy of Fallot. Try to put a box diagram so it will fetch you more marks. Divide it into these components, and I think that will do. Thank you.